Today, we're going to walk through pregnancy-associated acute kidney injury, also known as PrAKI. This topic matters so much for us as midwives because we are often the first to see early signs. My goal is to help you feel confident in recognizing risks, understanding the physiology, and knowing what your role looks like in the management and follow-up. Everything we'll cover comes mostly from the recent international consensus, so this is truly evidence-based and current. PrAKI is not rare, and it's not benign. It carries significant risks for both the mother and the baby. The consensus highlights huge increases in maternal mortality, cardiovascular risk, and fetal complications like growth restriction and preterm birth. As midwives, this reinforces our vigilance to pregnancy and postpartum assessment, and it can be life-saving. Early recognition truly changes the trajectory for the woman. There is a 13-fold increase in maternal mortality in these patients, and there's higher risks of stillbirth, preterm birth, and fetal growth restriction. There is also an increased risk of cardiovascular events, like I mentioned. So here we'll talk about the big three that you'll see that cause PrAKI. So preeclampsia, hemorrhage, and sepsis. Preeclampsia is the #1 cause worldwide of PrAKI, and we see PrAKI triggered by pregnancy-specific conditions like HELP, acute fatty liver, hyperemesis, or even obstructions from the gravid uterus. So the big point is that whenever the maternal system is under stress, such as vascular, volume, or the inflammatory process, the kidneys are impacted. So why midwives must recognize PrAKI early? We are incredibly positioned to notice subtle changes. The relationship that we have with moms and their families is unique when comparing it to the medical model. Often we get to know them better. They share things with us that they may not share in a different setting. And so we may notice subtle changes. A woman who's sicker than expected with hyperemesis, someone who has borderline blood pressures, someone who's losing more blood than normal. We often can spot trouble early and escalate the care quickly. So don't underestimate your ability to recognize that something's wrong. Outcomes can dramatically improve, and the consensus report repeatedly emphasized that the importance of timely diagnosis and management can significantly impact the outcomes for the mom. So early recognition reduces that progression to the severe disease state, and it can improve the maternal and fetal outcomes. So when there's a delay, it can increase the risk in a need for dialysis, long-term chronic kidney disease, ICU admission, and neonatal complications like NICU admission and prematurity. I do want to just kind of bring up a case. I had a patient that I took care of, and she was she had, at the point that I received her, she was already several months pregnant, but she had a chronic kidney disease at this point, and she was actually on dialysis several times a week. It was really sad and really detrimental to her health and just her life, because she had to go several times a week for dialysis. And anyways, the dialysis team that she was getting care with, they would kind of, talk about how they were she was their favorite patient. She was quite a bit younger than most of their patients that they saw that were there for type 2 diabetes, like uncontrolled type 2 diabetes. This patient, during the course of her pregnancy, her blood pressures were terribly controlled, and she was on a whole lot of medicines. The diabetes clinic and the nephrologists and everybody there were the ones that were managing her medications because her blood pressures were so uncontrolled. And the problem is that, with dialysis, it filters your blood. And so trying to keep this patient controlled with blood pressure medicines was quite difficult. So I talked to the patient a lot, and she had an not unknown history of kidney disease prior to this pregnancy, and she did know that she had some high blood pressures in the last pregnancy, but like most patients, she did not have follow-up in between her pregnancies, and so she had some mild high blood pressures with her prior pregnancy, did not receive any follow-up, no family practice primary care in between the two pregnancies. However, I did find about a year before her current pregnancy, she presented to the ER. Her serum creatinine was elevated, and so that did show that she actually already had some kidney disease, and her GFR was so low. Unfortunately, it was documented in a chart that the providers said that she had kidney disease, and according to the chart, it said that it was discussed with the patient, but unfortunately, the patient did not realize what a big deal that was and did not seek follow-up and did not manage her blood pressures. And so, unfortunately, by the time she presented in pregnancy, a year later, her kidneys were so damaged, and she had to have dialysis several times a week, like I said. So I just say all this to say that when you notice something, you need to say something, and you need to really, like this patient, she did not have insurance. She did not have a primary care doctor. She did not see anybody in between her pregnancies. And so she really was lost to care. And, if she would have known, maybe she would have managed her blood pressures well and not resulted ultimately in the situation that she was in when I saw her with dialysis several times a week. So all that to say is that you can make a difference in the lives of these patients. So think of this as your mental checklist. So anytime So think of this as your mental checklist. Anytime you see something significant like vomiting, infection, bleeding, hypertension, or someone who's taking nephrotoxic meds, which we'll talk about a little bit more later, remember that the kidneys are vulnerable. If something in your gut says this mom is not looking right, you need to pause and consider. Make sure that when you look at the chemistry, the CMP, that you're looking at all of the levels. You're not just looking at the liver function testing, the ALT and AST, that you're not just looking at the glucose, that you're looking at the serum creatinine, that you're looking at, the full CBC. So just make sure that you think about that this could happen. Those patients that have infections, those patients that have recurrent UTIs, just keep in the back of your mind. I'm not trying to scare you or make you think that every patient is going to have kidney injury, but just know that it is possible, and you need to be diligent. And if you feel like you should order a CMP just to check, then that's okay. You may want to consider that. So the kidney health assessment is really the first foundational first visit assessment. The consensus that happened recently recommends doing this on all pregnant patients. And so this is a potential DNP project because we're not actually doing this yet in most cases. So this includes a serum creatinine, blood pressure. Of course, we do that on everyone. A urinalysis, we do that. We don't do that on everyone, but we do a urine culture, a medication review, screening for risk factors. So it's not a complicated assessment. It's simply about being thorough. And remember, pregnancy lowers creatinine, so small bumps matter. So if you see that it's elevated, then that you need to pay attention to that. So if your initial kidney health assessment is normal, but you identify risk factors factors for PrAKI, the consensus is clear. You need to continue ongoing assessments or kidney health assessments throughout the pregnancy. This is because the risk factors alone, even in the absence of that one time creatinine rise, or the lab results are normal, that it still puts the patient at a higher risk category for developing PrAKI later. So this looks like just a review of the nephrotoxic meds, a BP at every visit. You may do a urine dipstick on each patient, and then watch for things that can further put the patient at risk. So like infection, UTI, nausea and vomiting, dehydration. Creatinine is used strategically when things change. So if you notice that, okay, this patient is, has recurrent UTIs, or she has a UTI and she already was at risk, you could look at the creatinine again. So, and then you can also do a 24-hour urine for the quantitative proteinuria. So some of the risk factors for PrAKI include demographic factors, so advanced maternal age, a teenage pregnancy, minority ethnic groups, a high or a low BMI, different comorbidities that put additional stress on the kidneys, so diabetes, high blood pressure, heart failure, already having kidney disease, of course, acute infection, autoimmune disease, so like lupus, the use of illicit drugs or alternative medicines. So you need to think about, especially with midwifery patients, using a lot of herbs possibly. Pregnancy related risk factors, like a high risk pregnancy. Basically, the consensus says that anytime a pregnancy is labeled high risk, I think from a maternal perspective, think about the risk for PrAKI. The history of ART, previous or current preeclampsia or HELP syndrome, multiple pregnancies, septic miscarriage or abortion, any sort of hemorrhage in the antenatal or postpartum time, sepsis and intrauterine death, acute fatty liver of pregnancy, and hyperemesis, especially when there's like signs of dehydration, regardless of hyperemesis, and then kidney-specific risk factors. So acute kidney injury previously, nephrotoxic medications like NSAIDs, decreased renal reservoir, so like a low birth weight that the person was a low birth weight, and then proteinuria, chronic kidney disease, or UTIs that can cause damage to the kidneys. So changes in pregnancy can cause additional risk with PrAKI. So thinking about the vascular changes, the altered immune balance during pregnancy, renal tract obstruction with the changes during pregnancy, the placental changes, the risk factors that come with maternal factors, so pre-existing conditions like hypertension, diabetes, HIV infection, obesity, multiple pregnancies, and then other risk factors that can come with pregnancy, like TTP or hemolytic uremic syndrome, UTIs, different autoimmune diseases, and then nephrotoxic drugs that the patient could encounter. And then we talked about the pregnancy-specific pathologies in the last slide. So when we talk about diagnosing PrAKI, we want you to think about patterns. So patterns in creatinine, patterns in urine output, and patterns in symptoms. Diagnosis is not one number or one dipstick. It's looking at the full clinical picture, and the consensus is very clear that early systematic assessment is super key to the outcomes. So doing that kidney health assessment is very helpful, monitoring serum creatinine trends, especially in a patient that has risk factors, evaluating urine output, recognizing risk factors and insults, so those times when the patient is at risk, and then using the KD-IGO criteria when the pregnancy context, and we'll talk about that a little bit more. So serum creatinine is the key diagnostic marker. So pregnancy naturally lowers the creatinine so that even a normal number could represent a minor drop or a drop in kidney function. The rule is to look for changes in baseline. If the patient's creatinine goes from like a 0.5 to a 0.8, that can be significant in pregnancy. Even though a 0.8 could be normal, the change that patient is undergoing is what would be significant. So pregnancy physiology matters. If the lab auto reports a GFR, ignore it. This is because the pregnancy physiology makes the formula inaccurate, and so we do not want to diagnose with the GFR. It does the way that they do the equation underestimates the GFR, and then there's another equation that's used which overestimates the GFR. So basically, the importance is just make sure that you look at the creatinine, not the GFR. So normal pregnancy ranges for the serum creatinine is 0.35 to 0.87. It is the lowest in the mid to second trimester, and any rise above the pregnancy norms warrants evaluation. So when we talk about urinalysis and proteinuria, so urinalysis gives us early cues. It's also really easy to do. It's low cost for the clinic. Proteinuria may be normal, or it may be your first sign of preeclampsia or kidney disease. Hematuria is common but often benign. And we use microscopic confirmation to sort out who needs follow-up. So often this is done in the lab, so you're not doing this yourself. A dipstick or quantitative proteinuria can detect preeclampsia, glomerular or tubular disease, and pre-existing chronic kidney disease. A greater than 2+ microalbuminuria should prompt kidney evaluation. 1 in 5 pregnant women show dipstick hematuria, but only 15% have true disease. So the hematuria is not as clinically relevant. So what counts as a normal oliguria? So it's helpful clinically short-term. Low output during labor can be normal, but prolonged oliguria, which would be considered 6 hours in pregnancy or postpartum or 12 hours in labor, is not normal. So when the kidneys stop making urine, they are telling us, of course, that something is in trouble. So again, it's more prolonged oliguria because we're looking at not just a small snippet in time, but how the kidneys are functioning over a longer period of time. So again, when we talked about diagnosing PrAKI, it's dynamic. One creatinine is not enough. We look for rises, we compare it to the pregnancy norms, and we evaluate urine output. So context matters. Is she bleeding? Is she vomiting? Is she septic? Did she take NSAIDs or other nephrotoxic medications? And so that's how we will connect all the dots to try to determine if she does have PrAKI. If you're seeing this, the role for a midwife is to consult and discuss with your OB or the MFM what's going on. So the rise in the serum creatinine from baseline is the preferred method for diagnosis. If you don't have a baseline, so you didn't do she doesn't have a primary care visit, or she doesn't have an early pregnancy screen or assessment, you can use the pregnancy reference ranges. Serial monitoring is important, especially if they're above those ranges. And you should consider PrAKI when you have a rise, and especially with a new insult like preeclampsia, hemorrhage, infection. So if you have both of those together, then the diagnosis is a lot more clear. And then especially if you have no urine output or you have low urine output, as we discussed earlier. So the KDIGO criteria is used with clinical judgment. So we're not, they weren't created for pregnancy, so we use them wisely. So stage 1, so this is when you're looking at stages of chronic kidney disease. So stage 1 can look mild on paper, but it can represent major renal decline for a pregnant patient. So that's why it's difficult with pregnancy. They weren't actually intended or studied when they were developed for pregnancy, but a stage 2 and 3 are often associated with worse maternal and fetal outcomes. So, working in the MFM clinic, I definitely saw that. I saw adverse outcomes and also the pregnancy causing continued issues, and then having to have dialysis when they didn't have it in the, prior to pregnancy. So what counts as complete recovery? So recovery is not just looking to see if the creatinine is stable. It should return to pre-pregnancy or early pregnancy baselines. If not, the patient definitely needs follow-up because there's a long-term risk. Like I talked about that other patient that ultimately had to be on dialysis. So persistent evaluations may represent unresolved acute kidney injury, acute kidney disease, or pre-existing chronic kidney disease. So dialysis is not failure. So it's important. I know it feels like, it's obviously a very life-changing thing, but dialysis is support. The indications are the same whether a person is pregnant or not, and what changes is our awareness of the fetal well-being and the goal to limit uremia to reduce risks like polyhydramnios and preterm birth. These patients, if they're on dialysis, they're definitely managed in the maternal fetal medicine clinic. They likely are having a lot of visits, both, of course, with the dialysis, but also with follow-up, looking at the baby, making sure the baby is okay. Again, they're evaluated the same as a non-pregnant patient, looking for fluid overload, severe hyperkalemia, uremia, severe metabolic acidosis, progressive acute kidney injury. And the goal is to have the urea less than 12.5. Intermittent HD is most common, and continuous kidney replacement therapy requires a special dosing consideration. So again, this is all done usually in the dialysis clinic and with the maternal fetal medicine specialist. So again, just kind of talking about the midwife's role in diagnosis and escalation, we can make a huge difference. We can catch trends early, we know our patients well, and we escalate appropriately. It's a team effort. And sometimes, if the midwife, depending on the environment that they work in, they can still be a part of that team taking care of the patient. Again, we want to perform the kidney health assessment early and consistently, monitor for risk factors, identify abnormal creatinine patterns, evaluate urine output. When I have a patient that calls and tells me she's sick, whether it's the flu season and she's vomiting, or she's got really bad nausea and vomiting in pregnancy, I'm always asking about how often she's going to the bathroom, because if she has signs of dehydration, I want her to go to the hospital to be evaluated. And then avoiding nephrotoxins and collaborating with physicians and nephrology. The management principles, so it targets the underlying cause. So if we can start identifying the cause of what's causing the harm and the damage to the kidneys, and we can fix that, that's the best case scenario. So if it's a hemorrhage, we want to use isotonic fluids, blood products, tamponade, stop the bleeding, have surgery, preeclampsia, delivery, sepsis, treat the problem, obstruction, relieve the obstruction, and then nephrotoxicity, we want to stop the medicines. When we talk about hemorrhage-related PrAKI, this is probably one of the most common outside of preeclampsia. We want to stabilize the patient, identify the bleeding source, and of course, escalate as needed. So anytime you have a really significant postpartum hemorrhage, you want to be thinking about the risk for PrAKI. Medications, reviewing for renal safety, so avoiding nephrotoxic medications, so NSAIDs, of course, postpartum, aminoglycosides, and then certain antihypertensives. It is preferred if a patient has risk factors to do Tylenol because it is not nephrotoxic. So when we talk about the risk with NSAIDs, it reduces the blood flow to the kidneys. It can worsen oliguria. It can precipitate the acute kidney injury, especially if it's there's already a risk. And then aminoglycosides that we see more often, and those are antibiotics for serious infections. One of the ones that we see more often used is gentamicin. And so what happens is that the aminoglycosides accumulates in the renal tubular cells, and they cause direct tubular toxicity. And so this causes the kidney injury and related to that. It increases significantly in pregnancy because of the higher GFR and the altered drug handling. And so the risk is compounded with dehydration, sepsis, and hypovolemia, which are other triggers of PrAKI. So you want to make sure that that you avoid those medicines if possible. And then for antihypertensives, the ones that are more concerning are the ACEs, so the lisinopril, enalapril, which we're not doing in pregnancy anyways, and then the ARBs, so losartan, valsartan. And so these medications reduce the glomerular pressure by dilating the efferent atrials, and so that can cause reduced filtration, which can cause acute kidney injury. So you likely will not be prescribing those the antihypertensives, but the one that you want to look out for is the gentamicin and then NSAIDs. So with blood pressure management, so this is so important to manage blood pressure. Again, like I told you, that first patient that she, possibly I don't think she would have gotten to where she had if she had managed her blood pressures. So especially postpartum blood pressure control is really important to make sure that we want to prevent PrAKI. So watching for those trends, adjusting medications, having them come to the clinic quickly after delivery for follow-up blood pressure, so usually within a week, sometimes 5 days, sending them home with a blood pressure machine, having them take their blood pressure, and discussing, the guidelines of when to call you. And then, of course, with these patients, these would be collaboratively managed with your physician, just depending on where you're at, or sometimes they would take over these patients. So it's important that we have multidisciplinary care, especially as midwives, and we are a lot of times the experts at coordinating this. And so we want to loop in our physicians, our collaborating physicians. Often nephrology will be involved, maternal fetal medicine. This is so important that we manage these patients as a team. So just kind of to review with the PrAKI, so there's a paradigm for follow-up with these patients, and depending on the degree of severity will result in how we, follow the patients, how closely we follow them. This is just a kind of a table showing from the consensus the different follow-up. So you can see somebody who has no pre-existing comorbidities, limited hospital-limited events, term delivery, and the serum creatinine return to baseline or to normal. They say to consider the CAMPS, which is over on the other side. So that's kidney function testing, advocacy, looking at the medications, reviewing the blood pressure, planning pregnancy, future pregnancy, and then sick day management within 6 months. So having a follow-up in 6 months. And so you can see that, if they had severe PrAKI, where they had multiple comorbidities, they were on dialysis, of course, they need to be followed a lot more closely by a nephrology. So that just kind of shows like that continuum of depending on how severe it got. So postpartum camps, so this is the framework for follow-up. So looking at kidney function, advocacy, medications, pressure, pregnancy planning, sick day management. So it helps to make sure that we're covering all the critical areas that women need after having a pregnancy related acute kidney injury. So a sick day a little bit further, we check, so this is going into each of the components a little bit further. So for kidney function, we repeat the creatinine, we can monitor proteinuria. For advocacy, it's so important that we educate the patient on the risk. Like I said, with that patient, that I believe that if she would have known her risk, she would have gotten the follow-up that she needed. Coordinating the care across disciplines, which we as midwives usually do a really good job with that. Removing nephrotoxic meds and ensuring safety with breastfeeding. So if you change the meds, are they safe with breastfeeding? Monitoring and controlling postpartum blood pressure, talking about future pregnancy, discussing timing, medication adjustments, and then sick day management. So this is where we teach when to hold medication. So like diuretics when they're dehydrated, vomiting or illness, avoid NSAIDs, track urine output, and then knowing when to seek care. So just teaching them that they need to follow up early. Don't wait till you've gone several days, you're taking a lot of NSAIDs, things like that. They have to be diligent. So it matters to have this follow-up because women who with a history of PrAKI have the long-term risk of chronic kidney disease, hypertension, cardiovascular complication, and then having another pregnancy-related acute kidney injury in future pregnancies. So the good thing about camps with a consensus is that it gives us this clear, structured approach to promoting maternal health and preventing long-term disease. And so, I really appreciate that the consensus came up with this because I feel like often guidelines, especially postpartum, can be very difficult because it's not as clear. And so this gives us really clear guidance on what to do. So, in summary, PrAKI is common. It's serious, but it's often preventable. Early recognition, especially through the kidney health assessment, is essential according to the consensus. Management requires addressing the specific cause, so treating the cause, stop the bleeding, rehydrate them if they're dehydrated, treat their hyperemesis, treat the infection, avoid using nephrotoxic medication. Camps ensures that follow-up care postpartum, and then making sure you work as a team so that midwife physician collaboration is crucial for these high-risk patients. And then this is the reference. You're welcome to go read it. It's a great article. They have a good review of this, and so I highly recommend looking at that.